If you are an expecting mother or father, plan to have children in the future, or plan to work in neonatal care, this video may be for you. Myself, Quinton, as well as Madison E., Madison R., and Gabriela are here to present hypoplastic left heart syndrome.
What is hypoplastic left heart syndrome? It's the most common form of congenital malformation, and it is characterized by the abnormal development of the left ventricle, which is circled here. This leads to decreased blood flow out of the aorta, which supplies the body with blood. The result is that newborns often do not survive more than a few days.
Low birth weight, twin births, gestational diabetes, maternal use of organic solvent products, and maternal upper respiratory infections are the most common risk factors which cause approximately 10% of hypoplastic left heart syndrome, or HLHS cases.
While there's no definitive cause of hypoplastic left heart syndrome, there are some genetic conditions and chromosomal abnormalities that are associated with it, the most common of which are listed here. In addition to genetic causes, it is known that if the blood cannot flow through the body properly, then the left ventricle may not form. Here's a quick overview of how the fetal blood is supposed to flow. First, the blood flows into the right atrium. Then some goes into the right ventricle, while the rest goes in through a structure present only in the fetal heart into the left atrium. From there, the blood goes into the left ventricle and then into the aorta, which supplies the body with blood. If the blood does not flow through the aortic valve to the body due to a malformation, then the aorta and subsequently the left ventricle will not form properly. Similarly, if the blood cannot flow through the mitral valve into the left ventricle, then the left ventricle will also not form properly.
Echocardiographic imaging at the 24-week ultrasound may detect anatomical variations that allow for detection of HLHS, including an enlarged right ventricle and a small dysfunctional left ventricle. Postnatal diagnosis is accomplished through the use of echocardiography as well as through physical changes that can be observed once a baby is born, such as cyanosis, which is a blue coloration of the skin of the hands, feet, and lips, as well as cool extremities and trouble breathing. 90% of babies with HLHS will experience a honeymoon period where the ductus arteriosus persists for an abnormal length of time, allowing blood flow to the systemic arteries despite an underdeveloped left ventricle. When this eventually closes, the onset of HLHS symptoms occurs, including cyanosis, respiratory distress, and heart failure. Without surgical intervention, 95% of newborns with HLHS will die within the first 2 to 3 weeks of life.
Babies who develop HLHS early in pregnancy sometimes have an improperly functioning aortic valve called aortic stenosis, where the valve between the right ventricle and aorta is too narrow or dysfunctional. If this defect is found early enough in pregnancy with an echocardiogram of the baby's heart, it can be corrected with surgery. This procedure is called fetal aortic valvuloplasty and begins with putting the mother under general anesthesia, rendering her unconscious. Then, using ultrasound for guidance, the baby is manually positioned in the uterus so that the chest is facing forward. The baby is then given pain medication and muscle relaxants to prevent movement and pain by a needle into the thigh. Using ultrasound again, a needle is guided through the mother's abdomen, uterus, and finally into the chest wall of the fetus. The needle is then guided into the left ventricle, and a wire is passed through the needle and is placed across the aortic valve. A catheter with a small balloon is then placed across the valve, and the balloon is inflated, making the valve larger to encourage more blood flow. This procedure may prevent HLHS or make the baby a better candidate for surgery after birth.
Staged palliative surgery is the only means for survival into orthopedic heart transplant. In the Norwood procedure, performed just after birth, a small vessel between the aorta and the pulmonary artery is removed. Next, the base of the artery to the lungs from the right ventricle is separated from its branches, the left and right pulmonary arteries. Thereafter, the undeveloped aorta is spliced to the base of the previously incised artery, currently attached to the right ventricle. Additionally, the developing wall between atria is cut out. Pulmonary blood flow is allowed with a shunt from a branch off the new aorta to the left and right pulmonary arteries. This procedure allows blood to be distributed to both the body and the lungs from the right ventricle. In the Stage 2 bidirectional Glenn or Hemi-Fontan procedure, usually conducted within 6 months of birth, the superior vena cava, also known as the SVC, a vein which brings deoxygenated blood from the upper body to the heart, is surgically isolated from the heart. either through incision for the bidirectional glen or blocking of its inlet to the right atrium for the hemifontan. The SVC is then attached to the left ventricle and the right pulmonary arteries to bring blood from the upper body directly to the lungs. Next, the graft from the new aortic branch to the left and right pulmonary artery is cut. In stage 3, the Fontan procedure, typically performed at 18 to 36 months, the inferior vena cava is disconnected from the heart and connected to the pulmonary artery. This is done either via an artificial tube or via connecting the inlets of the inferior and superior vena cava in the right atrium. 50 to 70% of patients who have gone through all 3 stages of palliation live to the age of 5 years. Overall, this is a very serious condition, and awareness is the key to optimal outcomes for those affected. Thank you for listening.